All right. Hey there, and welcome to Immune Matters, the podcast sponsored by the PIDTC, where we delve into all things related to the immune system. I'm Jack McDonald. I'm a pediatric immunologist at Cleveland
Dr.
Clinic.
Elie Haddad, an immunologist and bone marrow transplant physician scientist at CHU Saint-Justine in Montreal.
And Elie, I'm noticing an amazing difference to your accent compared to mine.
What? What? I have an accent? Yes. I come from France, and Montreal is a French-Canadian port, and that's my charm, let's say.
That's part of your many bits of your charm.
So we both care a lot about rare immune conditions and people living with them. And in this podcast, we are very excited to bring you the latest groundbreaking research and insights from the field.
Yeah, and another goal of ours is just to really highlight the stories from the patient's perspective and what these diseases are like for the patients suffering them. Just a reminder for everyone, this podcast is for educational purposes only. It's not any medical advice that we're trying to express, and our views expressed here don't necessarily reflect our employers or the PID.
For the NIH.
Or the NIH.
Yeah,
exactly.
And whether you're a provider, a patient, or just curious about the immune system, you're welcome, and we're very glad you're here. Now, let's get started.
And now we're excited to welcome our second guest on the podcast, Dr. Jennifer Leiding. Dr. Leiding, could you just tell us a little bit about yourself and your kind of where you're coming from?
Sure. So my name is Jennifer Leiding. I am a pediatric clinical immunologist that works at Johns Hopkins All Children's Hospital in St. Petersburg, Florida. I started my journey into pediatric immunology when I was a pediatric resident and started seeing patients in the hospital that developed really severe, unusual infections and had compromised immunity that led to their infections, and just really wanted to understand why those things happened and how to impact and prevent them in the future and help patients with those diseases.
Excellent. Well, thank you so much for joining us. I think where we could start is just, if you don't mind telling us a little bit of information about chronic granulomatous disease, and like what is this disease and what's going on here?
Yep. So chronic granulomatous disease, or CGD, which we're going to call it for short just because it's a mouthful, is an immune deficiency that's inherited, meaning that there's a problem in the genetics of a patient. There are actually 6 different genes that can lead to CGD. And CGD really is a problem in the immune system that allows patients to get a certain narrow spectrum of infections. Different cells are affected by CGD, primarily neutrophils, which are one of the immune cells that are really responsible for our immune system fighting, again, this narrow spectrum of infections. And so the infections that happen in CGD patients can be very severe and life-threatening. They can infect many different parts of the body, and can be deadly at their worst. Patients with CGD are also at very high risk of developing autoimmunity or other immune dysregulatory problems where the immune system is sort of turning on itself and attacking different parts of the body. And in that case, we have to treat those symptoms a little bit differently than the infections.
Why the name granuloma?
Why the name granuloma? Because patients develop granulomas. So a granuloma really is just a fancy word for a collection of immune cells, usually in places that they have no business being. So a good analogy or description, of this in CGD is in the lungs. So granulomas can form in the lungs where there's this collection of immune cells that really have no business being in the lungs and can ultimately compromise the function of the lungs. And so in CGD, this is a common problem that happens in many different organs in the body.
And it's because of infection that there are granuloma, or there can be granuloma without infection, or just because people don't know how to find them?
It's all 3. So granulomas can happen at sites of infection where the infection starts first and the immune cells are triggered to come fight that infection, but they do it in a dysregulated way. And so start collecting and congregating and really don't know how to clean up the infection that's there. We can also in CGD see granulomas in places that there is no evidence of infection, places such as the bladder where there's really not bacteria or other organisms that are normally found. And then there also can be what you just said, where we just haven't found the best tools or used the best tools. We suspect that there's an infection, but we're not able to isolate it, and therefore granuloma form at that site that possibly had an infection, but just isn't proven.
And Jen, you said something really interesting, I think, for our listeners, which is that immune deficiency, in the case of CGD, for example, the propensity for certain infections can also coexist with kind of a too much immune system or immune dysregulation. Can you explain that? Because I remember thinking as a medical student, well, if you have a low immune system, it's not like you can have autoimmunity or something like that. What's that all about? I think that's really interesting to discuss.
Yeah, I discuss it a lot, and I can try. I think there's still a lot to be learned
Sure.
In this area, but so both problems coexist at the same time. So in CGD, patients have this inability to produce superoxide, which is the molecule inside of certain immune cells that's responsible for fighting this narrow group of infections that I was referring to, or preventing the body from becoming infected with those organisms when we encounter them out in the environment. At the same time, the body in a patient who has CGD is overly amplified in many ways. So reacting to the environment and having a heightened sense of awareness of organisms that are in the environment and fighting against them, but doing it in a dysregulated way. So instead of following sort of the textbook of how the immune system is supposed to work to fight or prevent an infection, it does it in a chaotic, disorganized way that creates more damage than benefit. This also happens when there is an infection. So once that infection does come in, instead of fighting that infection in a normal response, patients with CGD have this heightened, exaggerated response that again causes more damage than value in fighting that infection.
It's very interesting.
So should we transplant those patients? Is their quality of life or survival transplanting?
Yeah. So transplant is definitely a therapy that we pursue in patients with CGD. And that's the major topic of our studies in the Primary Immune Deficiency Treatment Consortium, is to understand how patients with CGD benefit from transplant, or how best transplant can be performed in patients with CGD to lead to the best outcomes. So in our really large study that encompassed all PIDTC centers, we were able to show that patients with CGD do benefit from undergoing stem cell transplantation. This is a one-time therapy where patients receive a new immune system from a donor, replacing the defective immune system that they have present that's caused their CGD. And in that case, we see infections resolve. We see inflammatory disease or autoimmune disease that was present before transplant get better, and improved quality of life in patients that have undergone transplantation.
So what
you say infections resolve and autoimmunity inflammation get better, just because you didn't want to say resolve, or it's because they don't resolve, or what?
Well, resolve is a difficult thing to assess. So I think we can say, when I say get better, we know that which was there before transplant is no longer there after transplant. It's hard to completely give causation to say that the transplant is what led to the resolution or the absence of that symptom, but it's certainly heavily implied that that is what has led to the absence of that symptom after transplantation.
So Jen, if I'm the average, or let's say I have a son or something that with it, kind of the average CGD patient, we'll assume X-linked, what can I expect as the father of my son who's got this new diagnosis of chronic granulomatous disease? What do I expect as far as treatments up to and maybe including bone marrow transplant?
For a patient or for a family that has a new son with CGD, so let's talk maybe just a second about genetics.
Please.
So X-linked CGD, as you just asked about, is the most common type of CGD. Happens in about 65 to 70% of patients with CGD. Remember, I said there were 6 types. So this is one of the 6. And by X-linked, that means that it affects boys. It is typically inherited from moms or grandmothers or aunts, female carriers, who then pass it on to their sons, and they express the disease full-blown with CGD. So a young boy who is diagnosed with CGD often presents with an infection. That is usually how they are first presenting to the medical community. And so usually there's a sense of urgency to treat that infection, establish a diagnosis, and then sort of figure out what to do moving forward. There's certainly variability within CGD, even within X-linked CGD, from more severe to milder forms. I don't want to come across as saying that there is mild CGD. I don't believe there's any such thing as mild CGD. There's just less severe, although all being severe. So what could be expected? So patients with CGD are at high risk, again, of infections, a certain group of infections, and therefore are treated with antibiotics and antifungal medications to prevent the development of those infections. And so once a diagnosis is established, what's routinely recommended is the initiation of those antibiotics and antifungal medications, and that is lifelong prophylaxis. So something the child would be taking every day to prevent those infections. Even with that, patients still develop infections. So there are breakthrough infections, and the frequency is not totally understood, but somewhere around 1 major infection every 3 to 4 years is what's in the literature, even with compliant use of prophylaxis. So those are going to be the major things that start right away. There's also going to be long-term follow-up with an immunologist or somebody else who is qualified in the care of a CGD patient. And that follow-up, again, will be lifelong. And patients, during that follow-up, patients will be monitored for the development of infections and also the development of inflammatory or autoimmune disease. The likelihood of a patient, any CGD patient, including those with X-linked CGD, of developing that is around 50%. So we can expect that somewhere in this child's lifetime, he has about a 50% chance of developing some sort of autoimmune complication associated with CGD. So that's what life looks like without transplant. With transplant, the evaluation could be very quick. So where a patient might be referred to a bone marrow transplant physician and undergo an evaluation to identify who might be the best donor for that patient. And that's typically what I do for patients when I'm diagnosed a new CGD patient, is I at least do that investigation at a minimum to say, do we have any possible donors who match my patient either within their family or outside of their family? And once we have that information, then we can present to the family the pros and cons of proceeding with transplant with that particular donor that's been identified, or not going to transplant. And so that data is really necessary to have an informed conversation about transplant. And if the child then proceeds to transplant, that in and of itself is going to be a journey, which we can certainly talk about. But at the tail end, if all things go well, the child or patient is no longer going to suffer the effects of CGD. So they're not going to be at risk of infections. They are not going to be at risk of autoimmune disease. And that's assuming we come out of the transplant and it's been completely successful.
Thank you for sharing that kind of look from the patient perspective. Now I wanted to, and Ellie and I too, I think we talked about looking into your great research that you have done on CGD, excuse me. Could you just tell us a little bit about the things you're working on in CGD?
Yeah, so there's a few different things that I'm working on. I think within PIDTC, we are really trying to understand how inflammatory disease or autoimmunity affects transplantation. And this is sort of a two-sided approach. So we want to understand how transplant fully resolves autoimmune disease or inflammatory disease, and how best to perform that transplant in order to achieve that goal. So that's the number one thing we're looking at. The second, the other side of that coin is to understand how presence of the inflammatory disease, so how a patient who has autoimmune disease, how that disease impacts the transplant. So it's sort of looking at it from both angles. And that's really the secondary goal. So with the end goal being that patients have resolved their inflammatory disease and that transplant be the method that's used to do that, and how best to accomplish that. We also are trying to identify ways to predict the development of inflammatory disease or autoimmunity, so that when we take that patient that you just hypothetically talked about, we can tell that parent what their risk for their child is of the development of that autoimmune complication. So we want to be able to predict autoimmunity, and we want to be able to predict or follow control of that clinical symptoms. So meaning that if a patient were medically managed or received some medication to treat that symptom, right now we really have no tools to be able to gauge success with those medications or even with transplants. And so we want to be able to identify laboratory ways to do that. And so that's primarily what we're doing, like I said, in the PIDTC studies.
And Jane, could you let us know what the IDTC has showed great results or great information for the scientists in the world regarding transplantation in CGD? What are the important data that came out from those PIDTC studies?
Yeah, so I think we have found several important observations in the PIDTC CGD studies. So our largest study that was published in Blood about 2 years ago now identified a few really positive pieces of data, but also some concerning areas that we need to investigate more. So the first being that patients do very well with transplant for CGD. The survival was around 83% from transplantation. And like I said earlier, infections go away, inflammatory or autoimmune disease goes away. And our long-term data is quite good, some out as far as 10 to 15 years post-transplant, living, good lives, not suffering the effects of CGD. The concerning things that we have found, or the most concerning thing that we have found, is that there is still an intolerably high rate of graft failure. So patients with CGD, it's somewhere close to 18% in our data, who who develop graft failure. And what that means is the patient has received the new immune system from their donor and they have failed. So they have rejected that graft, and they have redeveloped their disease that was being treated to begin with. And there are several reasons this is intolerable. Obviously, that is not our goal, is we want to treat CGD and not end where we started. The other is that a patient has now received a lot of medications, including chemotherapy, as part of the transplant process. And so they will have sometimes the side effects of those medications, and again, without having reached the goal. And so we believe that this inflammatory disease that we've been discussing is likely a major cause of why patients are at risk of graft failure. And so the better that we can identify inflammatory disease and manage it and control it, the more likely we are to see less graft failure and higher rates of success with transplant.
Do you sometimes tell your patients that they are cured?
I try not to use the cure word. Well, so I do use the word cure, but I use it in a certain context.
Yeah.
So I think patients are cured of the effects of CGD, meaning that their day-to-day life is going to be very different on the other end of transplant. They're not, if all goes as planned and all goes well, we are not going to be needing antibiotics and antifungals, and we're not going to need to see an immunologist every 3 to 4 months. This might be a couple years after the transplant, but that will be the long-term end goal. And so they are cured from the effects of CGD. Where I get worrisome about using the word cure is that this is a genetic disease. and patients can still pass this genetic abnormality onto their children, and they are not cured from that. And so I make patients very clear that should they decide to have children and are able to have children, that there will be risks associated with that are no different than if they underwent transplant or not. And so that's the one piece I contextualize with patients, because I don't want them to leave thinking that CGD never has to be part of their life again, because unfortunately it still does in some respects.
Yeah, if I put myself in the skin of a patient, we try sometimes, it's difficult, but we try. If you propose something where you will never say that I'm cured. So it's sad, no? Because if I don't have the disease, if there is a full engraftment, and each time you measure the so-called chimerism, it's 100%. So it looks like I'm cured. Why don't you want to say the word cured? I understand the thing of the genetic, but for me, don't I deserve to be cured?
Yes, I like I said, I use the word cure, but I contextualize it, and I think that's the piece that has, in my opinion, needs to go along with it, so that there isn't any misinterpretation of what we're saying. Because what I don't want to happen 20 years from now, when I'm still an immunologist, is the child of one of my CGD patients showing up saying, you told my mother or father or whomever that they didn't have this disease, and here I am. Because they need to know that going, we live in the 21st century. There are ways that people can think about this when they have children, and we just need to arm them with the correct information.
I understand.
Makes total sense. And you were just kind of touching on something I think important, which is looking at this disease from the patient's perspective and also kind of that human aspect. So I want to shift gears if we can and just talk about what you've learned along the way from a human perspective, treating patients with CGD, participating in this research. Are there kind of things that have happened that have changed how you think about this process?
Yes, a lot has happened from a human element. So I'll add, just on a personal note, I myself am a mother. I have 2 children. And so I don't think any mother can help but sort of have empathy for other mothers who are going through something like this when they have children that are affected by a life-threatening disease.
Sure.
So I think the things that I've learned, I've now been practicing for close to 20 years, I guess 15 years, depends on when you count practicing starting. Sure. At any rate, a long time. So
long enough.
Yes, long enough. And so I think, the things that I've learned are really that mothers, I think, are impacted a lot by seeing their sons have this disease. They themselves often are carriers of CGD, and maybe we should talk about that in a second. But there is a lot of genetic guilt that goes along with that. So this concept of I've passed this on, many times unknowingly. So that is something that we need to address and talk about, and make sure these women are getting the help that they need to work through that. And then just some of the other human elements are that I do tend to push or recommend at least an evaluation for a curative therapy like transplant. And the reason I say that is that even in the best of circumstances, the life expectancy of a CGD patient is the 4th, maybe the 5th decade of life, which means that parents may be outliving their children. And I truly think that should be nothing that a family ever has to go through. And so I do, paint that picture a little bit. This is what life is going to look like without a transplant. This is what life is going to look like with a transplant. And the window for when we do that transplant is often in childhood. It's not when we're adults, although it can be successful as adults. I don't want to discount that. It's just often not that case. And so I try to paint a picture of what life will look like now under these circumstances or in the future, and guide families to help them make these decisions, which are very difficult to make.
Absolutely.
At the beginning, you said when you're a boy, you're more likely to have X-linked CGD, but just to clarify to the patients, you can very well be also a boy and having a non-X-linked, like an autosomal
Yes,
recessive.
absolutely.
But when you are a girl, for sure, it's not an X-linked.
And I'm glad you asked that, Ellie, because that's also another sort of important point that PIDTC studies have shown, and I kind of glossed over, is recessive forms of CGD. So the most common recessive form, so this will equally affect boys and girls, is defects in the NCF1 gene that causes P47 deficient CGD. And so historically, even when I was in training, we were taught that patients who have recessive CGD tend to not have as severe of a form of CGD. And therefore, definitive therapies like transplant were not necessarily offered as quickly to patients with recessive CGD. And in our studies within PIDTC, we have really shown that that's just not true, nor the case. And that patients with recessive CGD can have just as severe, if not more severe, clinical disease, and that they benefit just as much from transplant as those with X-linked CGD. And so really irrespective of genotype, we should be thinking about transplant for our patients as a possible therapy.
That's very important. And
Yep.
I think that's a message that is crucial. And thanks to the PIDTC, we could very well show that.
Exactly.
That's very important. And what about if I were a patient, I would say, but I heard about gene therapy, it's success, non-success. Should I wait for gene therapy or should I go to transplant? I know it's complicated questions, but what do you answer to those questions?
Yeah. So gene therapy is a really extravagant, awesome way of thinking about curing disease, including CGD, where we fix the genetic abnormality within the cell itself, or edit the genetic abnormality or replace the genetic abnormality. There's all sorts of technologies that exist. The reason gene therapy really hasn't taken off in the United States, in my opinion, is just the enormity of how to perform these clinical trials and the cost associated with it. So some of the reasons that people pursue or think about and want to do gene therapy are that it takes out this equation of needing a donor. A patient really is their own source or their own donor. We're, again, fixing the genetic abnormality right within the patient. It also takes off the table some of the transplant-associated risks that can happen with a traditional bone marrow transplant, most notably graft versus host disease. So those are some of the reasons people might think about it. Specific to CGD, the early trials had some complications associated with them, most notably malignancy, where patients developed secondary cancers that were directly related to their gene therapy. Of course, that's not what we want. We don't want to cure or treat an immune deficiency and then accidentally give another disease that could be equally or more life-threatening. And so those trials were stopped and people went back to the drawing table and really worked on how to develop better therapies. And so there are newer ones out there that are being explored that have shown benefit. But again, this sort of economic hardship in the background of the costs that it takes, the regulatory requirements that need to be met to be able to provide these therapies to patients are what are stumbling blocks. To answer your question about why would a patient look at that, so I think I touched on a couple of them. Another might be a lack of a suitable donor. So if a patient doesn't have a good match for a donor, then we're left with using alternative donors, which would be just lesser matched donors that have a higher risk of death with the transplant or other complications that might be alleviated by using gene therapy as the treatment choice.
Would you be okay to say that there is hope with gene therapy, but it's still experimental as compared to bone marrow transplantation, classical bone marrow transplantation, where we demonstrated, both us and in European studies, that it works?
Correct. I totally agree with that statement. I think it's still very experimental, worth thinking about, and definitely would encourage anybody who's listening that's, a science buff to think about pursuing those avenues of research because they're desperately needed for all patients, including those with CGD.
And Jen, you mentioned the burden that carrier moms have in the case of X-linked CGD. And I know more and more is being discovered that sometimes it's not just the psychological burden, not to minimize that, but also that they have symptoms themselves. Can you speak just briefly about that? Because I know some of our listeners may have grown up thinking that the carrier of an X-linked disease can't get the symptoms, right?
Yep. So it's not just how they were brought up, it's what we're taught, even in medical school, so that people who are carriers of genetic abnormalities aren't necessarily affected by that disease. And I think at least in the case of X-linked CGD, female carriers, so usually the sisters, mothers, aunts, grandmothers, female family members of a boy with CGD are definitely symptomatic. Now, those symptoms can vary widely depending on the patient and depending on some of their the abnormalities with CGD. I touched on superoxide being the problem in CGD. So in a female carrier, they do make superoxide, although be it still not normal, they are making it. And so when those amounts drift below certain thresholds, we will see women or girls with X-linked, who are X-linked female carriers of CGD develop infections just like boys with CGD. So that's been reported. Within PIDTC, we partnered with the CGD Association of America and performed for the first time a study on self-reported symptoms of women or females with X-linked CGD who were carriers, of X-linked CGD. And it was widely successful. 171 women answered the survey. And from that, we were able to establish that female X-linked CGD carriers really have a host of medical problems that really affect every different organ system, and many of them being autoimmune in nature, which sort of touches on the dysregulated immune system that happens in boys with CGD. But a lot more needs to be done because what we were unable to establish was causation. So we know that patients have a lot of medical problems, and this has reputably been an ignored population. But how much of that is attributed to their carrier status is unclear and definitely needs to be looked at more deeply.
Thank
So
you.
tons of things to do, still tons of things to do, correct?
Yeah.
Tons of things to
Should rest too much because there's a lot of good work to do. Well, thank you so much for meeting with Elie and I and
Of course.
our listeners. We really appreciate you sharing your expertise on CGD. And I was quite impressed when I was preparing for this episode, going over all your publications and everything. It's just great work that you've done. So thanks, Dr. Jen Leiding, for meeting with us today.
Absolutely. Thank you, guys.
That's all for today's episode of Immune Matters. A huge thank you to Dr. Jen Leiding for sharing her time, expertise, and stories with us. If you enjoyed this episode, be sure to subscribe and share it with anyone who might benefit, patients, colleagues, or friends. As always, you can learn more about the PIDTC and find additional resources at pidtc.org. Thanks for listening. See you next time. The Primary Immune Deficiency Treatment Consortium, PIDTC, is a part of the Rare Diseases Clinical Research Network of the Office of Rare Diseases Research, ORDR, National Center for Advancing Translational Sciences, NCATS, National Institutes of Health, NIH. This work was supported by the Division of Allergy, Immunology, and Transplantation, National Institute of Allergy and Infectious Diseases, DAIT, NIAID, and the ORDR under cooperative agreements U54AI082973 and U54-NS064808 and grants R13-AI094943 and 1R24AI184316-01. The content and opinions expressed are solely the responsibility of the authors and do not represent the official policy or position of the NIAID, ORDR, NCATS, NIH, HRSA, or any other agency of the U.S. government.